Welcome back. Let's dive back into our discussions about substance abuse. All right, so you suspect or confirm you have a substance abuse situation. How do we approach it? The first rule of any EMS response applies doubly here: scene safety. These scenes can be quite dynamic. If it's an overdose where the person is unresponsive, the scene might actually be calm, perhaps panicky family, but the patient is down. Those are often easier to manage scene wise. But if it's a drug related behavioral emergency, like someone high on meth acting bizarre or a drunk person being aggressive, you must be on guard. Always ask yourself, is this scene safe for me and my partner? If there's any hint of violence, say dispatch mentions the patient is combative, or you arrive and hear shouting or see weapons, do not hesitate to get law enforcement on scene or wait for them to secure it. Your safety is paramount. You can't help the patient if you become a patient yourself. Also consider unseen dangers. Needles are a big one. If an environment suggests IV drug use, move carefully. People leave needles in cushions, on floors, etc. Use gloves, which you should anyway for standard precautions, and watch where you reach or kneel. In some cases, like a known fentanyl overdose cluster, crews might be wary of drug powder on scene. The actual risk of passive fentanyl exposure is very much overblown in media, but it's wise not to directly handle unknown powders without protection. If the patient is awake and hostile, keep a safe distance, ideally out of reach, and position yourself in a way that doesn't box you in. One recommendation is to stand at about a 45-degree angle to the patient, not directly in front, which can be confrontational, and not directly behind, which is unsafe. This also positions you to sidestep or move away if needed. Remove any potential weapons in reach. Sometimes folks might grab objects to wield, even something like a glass or a stick. Now, communication. This is huge. How you talk can either escalate or de escalate the situation. With intoxicated or drug affected patients, they may be irrational, emotional, or paranoid. Your demeanor should be calm, firm, and non judgmental. Avoid yelling unless absolutely necessary to get attention. Usually, a gentle approach works better because if someone is paranoid or belligerent, shouting can feel like a threat to them. Introduce yourself by first name and title. Hi, I'm Megan, an EMT. I'm here to help you. A simple phrase like that establishes who you are. Often, these patients are disoriented. Identifying yourself as medical and not police can reduce their defensiveness slightly. Some might be afraid of getting arrested. If you're not law enforcement, make that clear. Avoid accusatory questions or moral judgments. For instance, instead of, "How could you take so many pills?" you might say, "Do you know what or how much you took? It will help me to know." We're gathering info, not scolding. And if they are high or drunk, they might lash out if they feel judged. Use empathetic statements when appropriate. "I can see you're upset," or "I know you're scared right now." It doesn't mean condoning their drug use. It means you acknowledge their feelings. If the patient is agitated or angry, try to de escalate. Speak in a calm, low voice. Sometimes lowering your volume prompts them to quiet down to listen. If they're pacing, you might let them pace as long as they're not a danger. If they're yelling, let them vent a bit. As long as it's not escalating to physical aggression, then gently refocus them. "I hear you. Right now, I just want to check your blood pressure to make sure you're okay. Is that all right?" Giving them a bit of control by asking permission or offering choices. "Would you like to sit on the chair or the stretcher?" "Up to you." Can reduce combativeness. They often feel everything is out of control, so a small choice can help. Nonverbal matters too. Keep an open posture, hands visible, so they don't think you're reaching for restraints or something. Maintain appropriate eye contact, not a challenging stare, but don't completely avert your eyes either. If family or friends are present and are helpful in calming the patient, leverage that. For instance, if a mother can persuade her son to cooperate, let her talk to him, unless she's escalating things, which sometimes happens if there's anger. Use your judgment. All that said, sometimes no matter how good your communication, the patient may remain combative or uncooperative due to the substance's effects, like PCP or severe meth intoxication, for example. Always have a backup plan. Know your exit route, have PD on standby if needed, and don't hesitate to use team safety techniques. We'll talk more about restraints on the next slide if needed. One more subtle point. People with substance issues often expect to be judged. If you don't judge them and treat them like any other patient, you can sometimes see a visible relief in them, and they become more cooperative. A phrase I sometimes use is, "I'm not here to lecture you or get you in trouble. I just want to make sure you're okay." That reassurance can build a bit of rapport even in a short encounter. So to wrap this approach section, scene safety is number one, secure scene, PPE on, law as needed, and then communication is your best tool to gain trust and compliance. Be non-judgmental, calm, and empathetic. Now let's move into the nuts and bolts of assessing and treating these patients in the field. On this slide, we focus on what medical care and assessments we perform for substance abuse patients. This, of course, varies by the scenario, but let's cover the key steps. As always, ABCs first. Many substance related calls will be under the umbrella of altered mental status or unresponsive person. So, your primary survey is crucial. If the patient is unresponsive or obtunded, airway. Make sure it's open and clear. An overdose patient might have a relaxed tongue blocking the airway or could aspirate if they vomit. Use manual maneuvers, suction, and adjuncts, OPA or NPA, as needed. Breathing. Check rate and quality. Opioid ODs, for example, might be barely breathing. You'll need to ventilate with a BVM. Someone high on a stimulant might be breathing fast but effectively. Provide oxygen in virtually all overdose cases because many cause hypoventilation or hypoxia. If breathing is absent or severely inadequate, assist ventilations immediately. That's priority number one. Intubation is an ALS skill, but as all providers, regardless of their level, can maintain airway with BVM and airway adjuncts well. Circulation. Check pulses. Are they rapid, slow, bounding, weak? Control any major bleeding if trauma is involved. Sometimes intoxicated folks fall or cut themselves without noticing. Most overdose patients won't have external bleeding, but always check. Assess skin color, temperature, and cap refill as clues to perfusion. Simultaneously, form a general impression. Does this look like primarily a medical overdose or a behavioral crisis? Often you might not know yet, so treat what you see. Like if they're not breathing, you breathe for them, regardless of cause. Next, try to identify the substance or at least the class. Sometimes it's obvious needle in arm and barely breathing, likely an opioid. Or wild agitation, sweating, possibly police already restraining them, maybe a stimulant or PCP. Clues like pill bottles can tell you if they took a bunch of, say, Xanax benzo or beta blockers, even less common, but pill overdoses happen too. Bystanders are very helpful. Ask, what did they take? How much? Did anyone see them use something? People may be scared to tell the truth, but emphasize it's purely for medical care, not to get anyone in trouble. One tool at your disposal: glucose check. It bears repeating. Many intoxications mimic hypoglycemia and vice versa. It's protocol in most places to check a blood sugar on any altered mental status. If you find a low blood sugar, treat it or get ALS to treat, and you might solve or partially solve the AMS. Even if they did take drugs, hypoglycemia might be compounding the issue. For example, an alcoholic could have very low sugar and improving that could wake them up some. Now, specific interventions: naloxone, Narcan. This is a big one. If you suspect an opioid overdose, signs like respiratory depression, pinpoint pupils, drug paraphernalia, known heroin use, then administering naloxone can be life-saving. EMTs in many areas can give intranasal naloxone, and advanced EMTs and paramedics can administer it intramuscularly or via an IV. The dose might be 1 milligram or 4 milligrams depending on the device for IN and IM, and will start at 0.4 milligrams IV and titrate it up to respiratory drive. When you give Narcan, be prepared. The patient may start breathing and even wake up, but they might also come up agitated or upset. Waking up in withdrawal is very uncomfortable. They may suddenly feel pain or acute opioid withdrawal symptoms. It beats being dead, but they won't be happy. So as they rouse, speak calmly, hold off any physical aggression they might show. They might flail or push because they're disoriented. Importantly, even if they fully wake up after Narcan, transport is the goal because Narcan's effect can wear off in 30 to 90 minutes, while the opioid, especially long-acting ones like fentanyl derivatives, could still be in their system longer and cause them to relapse into respiratory arrest. We'll reinforce this to them. The medicine we gave you will wear off, so we have to get you checked out. Other antidotes. For benzodiazepines, the antidote is flumazenil, but EMS does not regularly carry this. Hospitals rarely do either because it can cause seizures in chronic benzo users. For overdoses like certain narcotics or others, usually Narcan is the only pre-hospital antidote. For carbon monoxide, if you consider that a substance, oxygen is the antidote. For organophosphates, not really a substance of abuse, more a toxin, atropine, but that's hazmat ALS territory. More toxicology and antidotes is discussed in a separate lecture. Activated charcoal, BLS providers might carry it, but its use in the field for overdoses has waned. It's only useful if the ingestion was recent and the patient is alert enough to drink it, and even then, many medical directors prefer it be given in hospital due to aspiration risk. Typically, we do not give charcoal in the field for substance abuse calls, especially if they are not fully alert. If the patient is agitated, hallucinating from drugs like meth or PCP, you may need to consider physical restraint for safety. This is a last resort, But if they are endangering you or themselves and are too out of control to reason with, you might have to. For more information about agitated psychiatric patients, please head to the Agitated and Excited Delirium lecture series. For stimulant overdoses, like a meth overdose where they might have chest pain or be hyperthermic, manage what you find. If chest pain, treat as cardiac event, oxygen, ALS for ECG, and perhaps meds. If hyperthermic, start cooling measures. Remove excess clothing, fanning, wet towels. If they seize, handle as a seizure, protect airway, ALS for IV benzos. Trauma. Always scan for injuries. The patient could have gotten hurt while high. Maybe they fell downstairs, got in a fight, crashed a car. They might not even feel injuries due to intoxication. Check head for bumps, body for bruises, or bleeding. This is where a good physical exam is important because your patient might not be reliable in telling you where it hurts or what happened. After initial stabilization, transport decision is straightforward. These patients need to go to the hospital. The question is more how and with what resources. If they're stable and cooperative, great. Calm transport on a stretcher. If they're unstable, like still comatose after Narcan with uncertain airway, rapid transport, maybe rendezvous with ALS for intubation needed. If they're violent, you might need police to ride with you or follow you closely while the patient is restrained. One scenario to be aware of ethically: the patient who wakes up after Narcan and refuses to go to the hospital. This is tough. Technically, adults who are alert and have decision making capacity can refuse care. But are they truly in a state to make that decision? They just were dead a few minutes ago, and the drug could wear off. Many EMS protocols consider an overdose patient at high risk of losing capacity, meaning you may have grounds to insist on transport under implied consent because they might not fully grasp that they could stop breathing again. If they absolutely refuse, involve medical control and law enforcement if available. Some areas have laws allowing temporary detention of overdose patients for evaluation because it's a life threatening situation. It's a gray area we navigate carefully, weigh autonomy versus our duty to protect. In the moment, try to persuade, I understand you want to stay home, but I need you to know the medication I gave you is likely to wear off in the next hour. You could stop breathing again. We would feel a lot better if you came to the ER so they can keep an eye on you for a little while. You don't have to stay overnight if everything checks out, but let's be safe. Often, patients will agree when it's framed that way. If not, get on the radio with the doc, document capacity evaluations, etc. It can be tricky. So, in summary, for treatment, support their vitals, ABCs, oxygen, ventilation, give specific antidote if indicated, manage whatever symptoms and injuries they have, and get them to the hospital. Safety measures like restraints or law enforcement may be needed for certain drug presentations, and always reassess frequently. These patients can change level of consciousness or behavior rapidly, for better or worse, as your treatments take effect or as drugs metabolize. We will wrap up this lecture here. Please join me in the next lecture to discuss eating disorders before we dive into some case studies. See you then.